Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Welcome to Talking Therapy. This is Marvin Goldfried.
And Alan Francis. Good morning, Marvin. It's always great to see you.
Always great to see you. It's raining in New York, and it's probably beautiful sunshine
San Diego.
in California, in San Diego. Great. Well, so I would like to take off from where we were in our last podcast when we were talking about common stages of change, and Alan, you brought up Rosenzweig's paper, so that motivated me to get a copy of it. And here's the fascinating thing: it's only 3.5 pages long, and there are no references. Published in not necessarily a first-tier journal of orthopsychiatry. It's been buried for years, and only in more recent decades has it come out. But it was really just incredible. So I just want to...
He was only 29 years old when he wrote that.
Really?
And it occurred to me recently that he died in 2004 at Berkeley. And it was crazy that I never visited him. I used to be there all the time.
Really?
It would have been the easiest thing in the world to get to know him. I knew about him, and I should have made that phone call.
Yeah. Well, it's kind of nice, but that is making this impact. And it's kind of interesting that it's only 3.5 pages, which just struck me, and no references. And it was kind of like a throwaway. And the date was 1936. So basically, what was the therapy? It was Freudian therapy.
He was also a friend and I think classmate of Skinner's.
Really?
And he had developed this idea that the therapies had a common factor, and that all the dodo bird, and that there would not be a major difference, an outcome across the therapies. He developed this when there was no psychotherapy research.
That's right.
It's all
Exactly.
intuition.
Yeah. So let me quote him. He said, beside the intentionally utilized methods and their consciously held theoretical foundations, there are inevitably certain unrecognized factors in any therapeutic situation, factors that may be even more important than those being purported to be employed. What it is still necessary to ask accounts for the results that apparently diverse forms of psychotherapy prove successful in similar cases. And then he adds, however, certain forms of treatment are likely better suited than others to certain types of cases.
The miracle here is that psychotherapy as a profession was only about 20 years old at that point.
Yes.
There were very few clinical psychologists in the world, very few social workers, and most psychiatrists were still working in hospitals. So even before there was a real profession or professions of psychotherapy, he had intuited something that the field is yet to absorb fully, and unfortunately didn't listen to, developed all these crazy schools rather than realizing that we had much more in common than what separated us.
Right. The patient was fit into the school as opposed to the therapy being tailored to the patient.
It's a profound statement.
Now, but that is what the research literature is. And there's a gap here because the clinical literature and the clinical experiences and observations is anything but that. Most therapists draw on different approaches. But, the whole gap between research and practice, that's another podcast. I think what would be helpful to follow up on our last week's talk would be to talk about both the similarities across different orientations with regard to the several stages of change, but also the differences. So, for example, we spoke about the first stage of change, where the person's life is not working, but they have no idea as to the reasons why. So these reasons are, quote, unconscious. And with the therapy explanations, they become conscious reasons. They become aware of why their life is not working. Here we have differences across different schools of thought, because this is the essence of psychodynamic therapy, insight over a long period of time.
Or a short period of time.
Or a short period of time. It's the major thing. It's also the key aspect to cognitive therapy, which focuses on not insight, but awareness of core beliefs. And it's very much Gestalt therapy and person-centered therapy, where the focus is on increasing awareness. So it's kind of interesting. And sometimes that's all that school does, at least consciously, at least deliberately. And then maybe at a later period of time, and you know more psychodynamic stuff than I do, the working through part involves more than just awareness, doesn't it?
Of course, corrective emotional experiences in and out of the sessions. I think that what you're pointing out is that the second two parts of your four-stage model, where people have the corrective emotional experiences that help to change how they see themselves in the world, that those two parts don't necessarily have to happen during a therapy, that the person may acquire awareness and that may drive them to do things they would otherwise be afraid to do outside of treatment. And sometimes just the beginning two stages may promote the person getting to the third and fourth stage on their own.
Mm-hmm, mm-hmm. And the thing that I find interesting, but also, disheartening and disappointing, is that sometimes the school of thought says this is all you should do. Let me give you an example. Les Greenberg, in his wonderful work on Gestalt therapy. Now, he was trained both as a person-centered and a Gestalt therapist. So he did Gestalt work within the context of a good relationship. Very different from Fritz Perls, who didn't care very much about the relationship. But the goal was increasing awareness. And I would speak to him and I'd say, Les, okay, once they get awareness, don't you encourage them to do things differently? And he said, no. And why? Well, because the school says that's all you need to do. But over the years, we interacted and we changed each other. And finally, he did acknowledge that maybe he can't suggest, that it's not cheating, that once the person becomes aware, the suggestion can be made that they do things differently.
Well, it's a real problem when anyone feels that it's cheating if they do what a patient needs because they're not following the school.
That's right. That's right. And sometimes what a person does or the therapist does is they don't tell anybody else that they're doing it because it's against the religion of the school. So that's interesting. So there's a common principle, a common stage of change across orientations, but there may be more time spent at one stage than the other. So I've had experience with patients who've been in psychodynamic therapy for many, many years. And it's taken a while for them to realize that it was time to act rather than just time to become aware.
I think it's really important that people not have the idea that the only way a patient can achieve the complete four stages of change is if they're in a long-term therapy.
Yeah.
The brief therapies, whether they're psychodynamic focal therapy or cognitive therapy or behavior therapy or Gestalt therapy, the brief therapies can have and should have the same 4 stages, but telescoped and concentrated and focused on.
Right.
And as I say before, and I like to say over and over again, I've had more success with many people in 15 minutes than I've had with others in many years. That sometimes you can get the ball rolling with the early stages in a very brief consultation, and then the person carries on in their lives, and you get virtuous cycles where previously there were vicious cycles.
Right. And to a great extent, it's a function of the problem. So if somebody is afraid of speaking in public, I don't know how much time is needed for them to become aware. I think what they need are the experiences.
Exactly right.
And the interesting thing is that sometimes the experience of changing brings about an awareness. Now I know why I was so afraid. I had that problem in 3rd grade and people were laughing at me. And now things are better, but I was able to change without realizing that I had this experience in 3rd grade.
That's exactly right. It affects at least my referral behavior. So when people present with fairly straightforward, condensed, isolatable problems, I don't usually send them to a psychodynamic therapist because I'm concerned that he may make more of the problem than it really is, want to go back to early patterns in life where the focus probably should be on that pattern in the here and now. On the other hand, if people present with long-standing patterns of personality malfunction, then I might prefer to have a psychodynamic or a cognitive behavioral therapist because they will not be so impatient to get straight to any one symptom, but rather see the symptom as it's embedded in the whole character style or schema of the individual.
Yeah. And of course, this requires a case formulation to understand what factors are causing other factors within the individual. But when it comes to specific phobias, the evidence is very, very clear that having the person gradually become in contact with the feared situation or feared object, if it's not harmful, they become less afraid. I once had to be a discussant on a panel, and the presenter was psychoanalytic and was talking about a patient with a phobia and how the treatment lasted several years before the person was able to get rid of their phobia. And I was really hard put to figure out how to make comments on this. So I decided to tell a story that Charles Lamb had told about how roast pork was invented in ancient China. I don't know if you know that one. You do. Probably apocryphal. But as the story goes, as you undoubtedly know, the swineherd's hut in which he kept the pigs caught fire, burnt down, and roasted all the pigs. And this was the origin of roast pork, presumably. And what this caused people to do is to build huts, put pigs in, and set the hut on fire. And this happened over a period of time until they figured out that there was a primary principle underlying this, and that you didn't have to go through this whole procedure. So that was my commentary. I finished my commentary and I ran like hell.
It's exactly what worries me about therapists who are slavishly adherent to one or another school, that they will be hammers always looking for the particular nail that school likes to hit, and often confusing their desires and their training with what the patient really needs. And I think every therapist should be competent at psychodynamic techniques, at cognitive techniques, behavioral techniques, and Gestalt really underlies all of the insight-driven treatments. It's a way of understanding what Gestalt's about. So we need therapists who are much more flexible, eclectic, and capable of dealing with the patients they see, not with the theories they read about in books.
Right. It's easier said than done. and there are lots of reasons why this is difficult to achieve. One of the reasons, I think, is that it may not make sense to certain people. So I would maintain that if you start by talking about the change process that makes sense to the therapist, regardless of orientation, then you have a point of agreement, and use that as a foundation or a stepping stone for saying, okay, to achieve this stage, you need a principle. So the principle of creating awareness moves the person from the first to the second stage. But you don't do therapy with principles, you do it with techniques. So we start with a common stage, we move then to a common strategy of the principle of increasing awareness, and then we have the technique. And the technique can vary as to...
I think it's a great way of looking at it, Marvin. I think that when people are talking about theory, it's usually in abstractions and with lots of jargon. When you bring to bear the idea, let's not talk about your theory so much, especially since the jargons are probably very overlapping and emphasize differences that don't really exist. Instead of
the jargon represents the same exact phenomenon, but said in a different way.
Exactly what I meant, and better said. And what you're doing instead is substituting something that's experience close. Instead of having the experience distant theory, the experience close, what actually happens in the room that leads to change. And there we can get much more agreement and an ecumenical realization that the different techniques are complementary in producing that change, that none of them by itself is necessary or sufficient, but that together they form the proper toolkit that every competent therapist should have.
Yeah. Exactly. Well, I'll tell you another little story. I don't know, you know George Stryker?
No.
George Stryker was dean of Adelphi University Derna Center, where they train psychodynamic therapists. We were at a conference on integration, and we went to this place down in South America where the conference was, Iguazu Falls. And place. George was afraid. The way it's set up is that there are bridges that go over the falls, and he was afraid of heights. And he basically, he said, I can't go here. I said, what do you mean, George? We're all here. Well, I'm afraid of heights. I said, well, we can cure that. And he said, oh, you mean with that behavior therapy crap? I said, yes, you just came from a conference on psychotherapy integration, but it was very, very personal. And within 15 minutes, we cured him, and he was able to do it. And he wrote about it afterwards, that he was able to do this. So I think the personal experience of the therapist plays a very important role in having them believe in what to use in their therapeutic interventions.
Did he modify the training program at Adelphi to make it more eclectic?
I don't know. That's an interesting question. I've never quite checked on that, but he did come out and said it worked. And then it generalized to other situations, and he doesn't know why, and he will use it even though he remains psychodynamic.
Well, it's actually what Freud did. I mean, Freud was himself a person who advised patients constantly and said that you can't really learn sense in life without experience.
Yeah.
That he didn't expect everything to happen in the psychotherapy session that would improve people's lives. He understood that life experience is the great teacher, and therapy can help change the nature of someone's life experiences. But without those life experiences, without actually going out and being different, you're not going to be able, just understanding is not going to ever be enough. You actually have to do stuff.
You have to have that's right. I'll tell you another funny story. We may not finish everything we intended, but we can always continue next week. Jerry Davison, colleague of mine, good friend at Stony Brook, did some groundbreaking work on reducing fears with desensitization. Did a lot of research, wrote theory on that. We had our clinic at the university, and at that period of time, the faculty were also doing the therapy. He comes out of a therapy session to me and he says, Marv, I just did desensitization with the patient. And you know something? It works. I said, Jerry, you know it works. You publish. Yes, I know, but this is different.
And be more precise. Why was it different?
Because he experienced it, because he saw in front of his eyes how somebody who was fearful was able to get rid of that fear.
And before that?
It was theory. It was conceptual. It was technique.
And actually, some of the people who are the best theoreticians are the worst therapists. So
Yeah.
Freud was a pretty lousy therapist. He admitted it. He wasn't interested in clinical work. For him, it was a research tool, theory building mechanism. Ferenczi, who was a clinician who really cared about clinical work, is the father of certainly psychodynamic, but you could say all of psychotherapy, modern psychotherapy. So very often, not always, the Becks are the opposite, where they were great clinicians, but very often the person who can talk a good game can talk the talk, but maybe not walk the walk.
Yeah, yeah. Well, another great clinician was Wilhelm Reich before he got into orgone therapy. Yeah. And his book on character analysis is fantastic. It's very descriptive. Anyway, in the issue of stages, to a fault sometimes, behavior therapists move directly into behavior change without getting the person to become aware. And I think that has a history of dealing with specific phobias, that we can decondition or recondition specific kinds of phobias without knowing where they came from. And what happened is, I think as behavior therapists, we have tried to avoid the past because that was the hallmark of psychodynamic therapy, of becoming aware of the past and then having the insight and voila, change. So to a fault, many behavior therapists don't deal with the past at all, which is ridiculous.
It's the flip side. So the extreme, slavishly devoted, analytic, religious follower does too much in terms of producing insight, too little in producing action. And the slavish behavior therapist, just the opposite, too much on action, too little on insight.
Yeah, exactly. And what I have found with certain kinds of cases, and I'm not quite sure which it works for the best, is having them become aware that, yes, it has roots in the past, your issues. And we're not going to change the past, but at least knowing about the past and the past learning experiences you have kind of gives us an insight into your vulnerability in current situations. So we know potential triggers in the current situation that are needed to change. So it could be very, very useful. And it's a different use of the past than the psychodynamic past.
It's like George Santayana, those who are unaware of the past are doomed to keep repeating it.
Yeah.
And it gives more power to the behavioral exercises in the present if you have a rationale to explain it in the past. So what you're suggesting in general, I think, Marvin, is a Goldilocks solution, where therapists are not wedded to any one model to the point of slavish devotion, where people aren't extremists, and where they combine techniques in a mixture that's just right for that particular patient.
Exactly. And another thing too that I'm advocating is to let the patient know what the process is, so they know where they are in the change process, and they know what they need to do. They know that, yes, I need to act, and if I act, then maybe I'll feel better, as opposed to I have to get rid of the feeling until I act, and until I'm able to act. So the rationale, they need to know how they are changing so that they're on the same page strategically with the therapist.
Yeah, I was very influenced as a resident by a wonderful guy named Aaron Lazar, who parenthetically adopted 12 kids during his life as an effort to be useful to the world, a wonderful person. But he wrote a series of papers in the late 60s, early 70s about negotiating with patients, not making decisions for them, but making them full partners in the treatment planning and in the formulation. And I think the more the two of you are working together, the less likely you are to run into stalemates down the road. The more the patient understands what has to be done, the more they can do it. The idea of a blank screen is a terrible model for what therapists should be doing with patients.
Yeah. Right. And a corollary of that, if one is a CBT therapist and one thinks in terms of helping the person learn coping skills to cope with anxiety, to cope with certain thoughts, to cope with certain behaviors, if they're going to learn a coping skill, then don't tell them don't do the coping skill for them. Bring it out within the session so that they think about what they have to think differently. They become aware of their emotions. They become aware of their behaviors. They know what they need to do, because if it's a skill, they're the ones that have to do it. And a good place for it to start to emerge is within the session as well as between sessions.
Yeah, I'm wondering, I see a slight internal contradiction, I think, in what you're saying. Okay. So on the one hand, you're saying that it's important for the patient to understand the task. On the other hand, to change. On the other hand, you're saying don't give too much advice about how to accomplish the task.
No. Basically, what I'm saying is, if a person is being inhibited by a certain unrealistic belief, have them retrieve that belief in the session rather than necessarily tell them. Because basically, you want them to become aware.
I understand that, Marvin, but I think although there may be a crisp theoretical distinction, I'm wondering, how would you deal with the patient? Like, would you be shy about telling the person with public speaking phobia that it's a good idea for him to expose himself to situations?
No, not at all. No.
You're not waiting for them to figure out the coping skill.
No. You can tell what the coping skill is, but if they come in to the session and they're upset because of something that happened, rather than saying, well, the reason you're upset is this, you say, well, okay, what do you think the reason is? And then you prompt and lead them.
Yeah, you're talking about using a Socratic technique. Rather than didactic technique.
Okay. Right. And the reason for that is, if you want somebody to learn a skill, then they have to practice the skill as opposed to being told it. Okay.
This is exactly where Freud was not a good therapist, because according to the descriptions of him, and there are enough of them converging on the same picture, he tended to talk a lot of the time and to talk about how his theory applied to what they were saying, rather than to elicit from them their understanding of what was causing the trouble. So he used the sessions almost to confirm his theory rather than to allow the patient to figure things out.
Well, one of these days we should talk about Freud and his early roots and his seduction theory, where he found out that, he advocated that women were being sexually abused, and then decided that was not a good idea to advocate.
I have a lot of opinions on the ways in which Freud was an absolute intuitive genius on the one hand, the ways he borrowed from Darwin. So a lot of Freud is really on the shoulders of Darwin on the other. And the third, some of the things which may have made sense at the time, given the science of the time, which seem absurd now, given the science that we have now, but have managed to maintain their hold on people's thinking, even though they're very outdated.
Yeah. For the future, I think we ought to stay on the whole notion of where we have the similarities as a starting point, so that we can get therapists of different orientations to recognize those similarities. And then there are variations, and how these variations should be a function of the patient's situation and needs and problems rather than theory.
My
So good.
suggestion to you now, Marvin, is to give a coming attractions for perhaps next week's talk, because I think it's going to be way too big a topic to do in the next 5 minutes. So maybe the next 5 minutes can be a coming attraction.
Well, let's maybe next week, let's talk about principles of change. We're talking about stages. Let's talk about the principles of change that can move the patient from one stage to another, and then the methods of implementing the principle, which is where I think we get variations across orientations. Common principle, different methods.
Do you see the techniques as being fully complementary, or do you see them being at all competitive?
I'll let you know next week. Stay safe.
Okay, bye-bye.
Bye-bye.